ahead and get started. We did move up our regularly scheduled time to 11 o'clock. I had several people mention that, you know, the noon o'clock kind of lunch and learn time was a bad time. So we're going to try 11 o'clock. We've also moved our monthly meetings to every other month for the Swingbed education program, and wanted to bring that to your attention. So we will be having them every other month, and we are spending a little more one-on-one time with individual hospitals. So that allows us a little more grant funding to be able to do that. Want to thank Allie Orwick for all of her support from IRHA. She helps with the Zoom platform. On your calendar invite today, there are attached several PDFs, the presentation, and some Excel and Word documents to that calendar invite. If it does not show up for you, put your name in the chat and let me know, and I will send the items out to you in incremental emails. There are probably too many attachments for most of your emailing systems, and it seems like it attaches to calendar invitations a little more efficiently. We do have several new Swingbed contacts, and so I want to introduce myself. I'm Becky Royer, and I'm a consultant for the Indiana Hospital Association, and work on the Medicare Beneficiary Quality Improvement Project for the State Office of Rural Health through that contract, and want to thank Joyce Fillenworth and David Conrad for all of their support through that MBQIP contract work and allowing us to provide these Swingbed education sessions. Our speaker today is Kerry Dunning. Those of you who've been with us for some time know Kerry pretty well. Kerry is a national Swingbed consultant and expert in long-term care that has worked with our hospitals for probably about 3 years now. Kerry has over 35 years in healthcare industry and over 28 specifically working with post-acute care. And she is just a wealth of knowledge, has a lot of great contacts within CMS, and just keeps us very apprised of upcoming things that we need to be aware of and concerned with. So I will be turning it over to Kerry. I encourage you to open up that chat function, chat in any questions. Kerry has several different items that she's going to cover today, and also cover some of our most frequently asked questions recently that I think if you haven't asked the question, I bet it's a process or a policy you're going to be working on soon. So keep those questions coming into chat, and definitely feel free to unmute your line. You can do that by hovering either at the bottom or the top of your Zoom screen until the taskbar comes up and clicking off the microphone there. Or if you open up that participant list, you can also unmute your mic next to your name, and feel free to do that. And we try to keep the sessions as informal as possible and get your questions addressed readily. So, Kerry, I'm going to go ahead and turn it over to you. And Kerry is traveling, and so I'm forwarding her slides. So I will apologize in advance if I forward something too quickly. So, Kerry?
I just appreciate the help. And those that have been around me for a couple of years know that I'm rarely at home when I'm doing these. Today, I'm hanging off the edge of the earth in Bar Harbor, Maine, which in English is Bar Harbor, but I can't even say it because I spent half my life here in Maine. So I'm leaf peeping and doing some walking through the parks. But I want to really tie into this to say that we're going to cover some ground on a couple of things that are of great importance to the federal government right now, which means they're of great importance to us. And I'm not sure, one of them I know we really are working on, the other one I'm not sure we have worked on. And as Becky said, I'm going to start with a couple of questions that have come up lately. So you can pretty well tag this entire time period as get ready for survey. If you're not getting surveyed in your swing beds in Indiana, it's coming. I have clients in 5 states now where actually the state surveyors have told those hospitals when they've been doing hospital services that they're being trained by CMS to do swing bed surveys. So that means we really have to stay up to date with our compliance issues. It's a good time to remind you to go back and look at your policies and procedures, make sure they're up to date, so that you are ready for somebody to walk in the door, because they're very paperwork oriented with skilled care, and obviously swing bed is part of the skilled process. So Becky asked me to kind of quickly go over 2 things that have come up. The first one I think is a little easier, which is the PPD. And the rules are followed by the national rules, and Becky and I just discussed it, in your state mandates follow the federal ones. The difficulty we get in, I think for you guys would be, is if somebody gets the first shot in a referring hospital, but needs the second, when they come to you, you need to make sure that your policy covers that. You need to make sure that you are getting communication from the referring hospitals as to that they're in process of this, but have not completed the PPD in total. And Becky, I don't know if there's another question around that, if that covers it for now. Did you have anything
Just,
specific?
yeah, and also a question come up that's a little bit along the same lines is there a chest x-ray required by CMS on admission to a swing bed unit? And I was searching and asking the state to see if there were any requirements around that, and wondered if you could address that too.
Yeah, normally no, again, unless there's state requirements. Normally that would be done in two instances. One is that the admitting physician orders it, then you would be required to follow that. And the second is if somebody has, if you as an admitting site feel like somebody has a history, like TB or some of the other things that where chest x-ray would be a good follow-up. You probably, if somebody's gone through pneumonia and they've had a hospital stay, can get that information from the referring hospital. So I think it's common sense. If you're ever uncomfortable about something you're seeing or hearing, then I would ask your physician to order one, so that you get it right away when they come in the door. But it is not required to get into a skilled facility.
And definitely follow if it's currently a part of policies and procedures. I know
Yeah.
I talked with a group recently and it was a part of their policy, but also wondered if it hadn't been put in with the thought that it was a requirement. So just was seeking some clarification on that.
Well, as we go through different health things, like the pandemic being one of the most confusing time periods that I've ever been through in healthcare for a lot of reasons, as far as policies, we gather up things. TB is been basically dormant. It is not in Florida. It is an issue in Florida again, which, as many of you know, that's where I reside. It started around Orlando, so it was foreign visitors to Disney, which is always our test in Florida. So we have a problem with TB that may get some Orlando facilities, for instance, as they're admitting somebody to require a chest x-ray again. But that's specific.
And if someone could confirm for me, I may have lost. I can't hear Kerry.
I can't hear her either.
Medicare has 100 days coverage.
Kerry,
Yes.
this is Allie. We lost your audio for just a little bit there.
Can you hear me?
Yes.
We can now, yes.
Okay, hanging off the edge of the earth. You may have to warn me again because I didn't get any funny sounds on this end. So can
No,
you
we're
hear me?
not. Yes, we can now.
All right. I'm not going to move my mouth or my arm. So we're going to talk a little bit about the 20-day change in Medicare, meaning change in the way it's reimbursed. Skilled patients, skilled nursing, which means swing bed patients that are under Medicare, have 100 days coverage. And the first 20 days, if you're Medicare A, this is non-Medicare Advantage, all those plans have different rules, but Medicare A, traditional Medicare, the first 20 days, there's no copay. On day 21 through 100, then there is a copay which changes every year and is updated each October. So we're due to see what the next copay amount will be, going forward into the next year. So arbitrarily, somewhere way, way, way back when swing beds were becoming an issue and beginning to be developed, there was it was not correct, but there was somehow put in place that you had to discharge a swing bed patient by day 20. There was never any regulation. I think it was a choice of many hospitals, because what happens on day 21 is then the hospital is responsible for collecting the copay amount from the patients. And that it can be simple or complicated depending on your billing processes. And again, this is for swing bed, or if you have a skilled facility, it's not for any of your other settings. So it was just an arbitrary cutoff that was determined early in the process of development of swing beds, never a regulation, never having anything to do with it, except somebody didn't want to figure out if somebody was going to be have a Medicaid copay or have no financial resources for a copay, or what was going on. So that's really up to your facility. Where I get worried with the 20 days is it's arbitrary enough that if you accept a patient, you're supposed to be able to care for a patient. And if they need 3 or 4 or 5 more days or whatever it might be, and you're discharging automatically on day 20 and sending them to a nursing home, I think that's becoming more of a red flag. And that may be why some of you are asking. And on the other end of the spectrum, just to sort of prove the point, we have a number of skilled facilities and swing bed programs across the country that are keeping long COVID patients in their swing beds, particularly those that are not safe to go to a nursing home, even a skilled nursing home, because of equipment and or other needs that can be provided for them in a hospital-based setting for the swing bed. And some of those patients have stayed 60 and 70 and 80 days. So again, you have the ability. It shouldn't just be a policy to cut them off at 20 days. You may just want to do short stay business, and that's fine. That is why we've tended to do more orthopedic work over the years, or our rehab type patients. But the way I think swing beds are going to be used going forward is for medically complex patients. And I think we're in for a haul here with long COVID patients, and you may decide that's something that your community needs also. So Becky, does that answer that?
I believe it does. But if you do have additional questions, chat them in and we will get them addressed.
All right, so let's start talking, and Becky, you can go ahead and forward to the first slide that has info on it. So one of the things I'm really worried about with the swing beds is there is a trauma-informed care process in the United States in healthcare. And it's significant in skilled nursing because we are taking people that cannot always communicate. They have dementia or Alzheimer's, but they've had trauma in their background. And just the amount of dementia with behaviors that we've seen increasing substantially in nursing homes across the country in the last 3 years, 4 years, which tells you the pandemic probably set off some of that full blast, but they're unable to communicate what some of the trauma has been. So there is a dictate. And again, your swing beds fall under skilled nursing rules. And I think this is going to be one of the survey issues, is the training that is being done in your hospital. It should be done for all employees. And that's why I have a list there when I say who's in the room, who's getting trained. It's anyone from administration to your clinical staff, to your housekeeping, dietary, if you have a separate activities person, sort of, it's everyone that would interface with any patient. So you need to make sure, if you are not doing trauma-informed care training and it isn't routine, whatever that might mean, you can decide if that's quarterly, You can decide if that's for new employees with an annual update. They haven't dictated that yet, but it needs to be in place. Next slide, Becky.
Kerry, before we go on and get too far away from it, there was a question in chat regarding the length of stay.
Mhm.
If there is a higher probability that patients will need care after the 100 days, is it better to refer them to a SNF when they have at least half of the skilled care days available?
Yeah, so let me define that in different language that I think will keep you safer. If you think a patient can be discharged safely to a skilled facility and there's a bed available, I suggest you go ahead and do that. Whether that would be day 30 or 60 or 90 or whatever it might be, if there's going to be a long process. The question has always been with this, again, with the swing beds and the medically complex patients, we're better prepared in a hospital-based system to get somebody to X-ray or ER or to surgery and so forth. And that's why I said I think clinically complex patients are headed more towards the swing beds. But the point you feel like they can go to a skilled facility, Medicare would actually prefer it because you are more expensive to Medicare than the skilled nursing setting at this point. Does that make sense, Becky?
Yes.
All right, so the next slide we'll work with. I want, again, everybody needs to be trained. So here's some ground level questions you should be asking yourself, which is who among you has been trained for trauma-informed care that is specific to your swing beds and skilled nursing patients? One, they may have already been through a traumatic medical condition when they're hitting you, a new diagnosis like cancer or a debilitating disease of some kind. And that means also we're going to talk about the re-traumatization, which is we have to be trained, we have to be aware of our own trauma. And I'm going to say this several times today. Everybody has trauma, but everybody's trauma from their past may be on heightened alert because of the pandemic. The pandemic isolated us. It scared a lot of people. Friends died, family died. So we're coming out of a very, very tough time period. So when have you had your last training? And then think about your clinical team, including any agency staffing you have right now. They have to go through this training also. So make sure that you've got records of that occurring and they understand what it is. Services such as housekeeping, dietary, I've just said, we tend to overlook that, but they're in the patient rooms, things are going on, and they need to know how to report things to clinical staff. So you can ask yourself those questions. And the last one I think is really important is when somebody comes in for admission, having an education sheet or something that's available to say, look, if you're having difficulty with this stay or with your current status, I mean, again, they could have gotten some very bad health information for the rest of their life while they were in the hospital. Now they're coming directly to you. And then we've got families trying to figure out how to deal with family members when they go home too. The next slide, Becky. Excuse me. All right, so these are the main components. So this is a slide that you can go back to when this is over and say, are we doing these things? So for instance, are we training on the effects of all types of trauma? And there's a list somewhere later in this, and it goes anywhere from child abuse to spousal abuse to drug abuse to military veterans coming home to pandemics. I mean, there is no one variety of how trauma impacts people. I'm sure you have people that you know very well, people maybe even your family, that have gone through, like siblings have gone through the exact same thing, and one comes out strong and one comes out drug addicted. I mean, there's just no figuring out what it is. So we have to kind of recognize ourselves to be cognizant and aware of any trauma that may impact their ability to heal and get home. We have to continue to remain compliant with CMS material, and it's been coming out for 3 years now. Some of the material I've provided is things around it, support sheets for that. But if we need more of the CMS material, Becky, I'll be glad to send it to you. Recognizing signs and symptoms. And I'm going to go a step further, documenting signs and symptoms. In nursing homes, it's very easy. They get to know a patient, and they go, I had a guy in one of the nursing homes that screamed bloody murder at 4 p.m. every afternoon. And I'm not joking. You could set your watch by it. 4 p.m. unless you changed from daylight savings or something, but 4 p.m. he screamed. Well, first we tried to put him in his room, and the state said we couldn't isolate him. I mean, they were going to fine him. But if you're a visitor and you're going down the hallway and you hear this guy screaming bloody murder, it impacts everybody. So we had to explain to everybody coming in the door because we couldn't isolate him. And he did it till the day he died. So that's the extreme example that I can give, but we need to really make sure anything that you are noting, and that can come out from the depression and anxiety, whether they have those diagnoses already or not. It may help you kind of key in to talk to the physician if they need to have those diagnoses or medication or other services. And as I said, the re-traumatization is they come in, they've been isolated because of the pandemic. Now they've got a healthcare issue that's put them in here. And then we have staff that isn't listening to them or steps on their toe in some way that the staff member didn't even realize that was a traumatic issue for that patient. So we have to train to that and pay attention. Your care plan should reflect individual comments on whatever trauma might be there. So again, care plan is another area that state survey teams will be looking at. And the new one that has come out, it started pre-pandemic, so maybe 2018, we started the person-centered care approach, particularly in post-acute services. So that part of that is culturally competent. And I think I have a slide later, but basically Jacksonville, where I live, Jacksonville, Florida, we have a huge population of Eastern Europeans now. And so we have different languages. Because we've got like 9 countries that are in that block that are now living. We have different religions. We have different holidays that are being recognized. So that's culturally competent in our areas that we have to get to know what is important to those we may be caring for, with differences from those that typically have lived in Jacksonville in the past. We also need to make sure that we continually work with our own staff to self-identify their own trauma. You don't want them getting upset with a patient because they've been triggered. And that's just something they may be triggered, but what do we do with that will be important as we go forward. All right, Becky, the next slide.
Kerry, I also wondered if on this slide, I do have a copy of a organizational self-assessment.
Yes, that'd be perfect.
Helpful to individuals. So if you would like a copy of an organizational self-assessment, let me know and I will get that out to you, that it's a template that you can answer some very trauma-informed care questions to.
Thanks. Good point. All right. So when you're training now, this is just a check-off list for you. What is your plan? What is your system for training people? How are you handling new employee training? I would say, how are you even documenting that? How are you keeping the timesheets that somebody has had the training and so forth? So if state asks for it or the feds ask for it, you have that information. Is there different training for clinical staff and support staff? There is a base level for trauma-informed care that all of us become better human beings when we have it. But then there are those of us with job descriptions that can cause more traumatic events. So for instance, if somebody's a respiratory therapist and people can't breathe, they get anxious, that sets off trauma, and guess what? Then we're having to deal with it at a different level. So you need to think through those. And what are your barriers for getting the training? For instance, I just mentioned in my area, we have Eastern Europeans. All of us have different populations. We've discussed this on prior calls. They can be religious-based, they can be language-based, they can actually be immigrants, they can be all sorts of things, and we need to make sure that we're figuring out how we're going to handle this. State survey is going to ask you the last time you had TIC training, trauma-informed care training. So you need to be paying attention. If you hadn't had it in a while, you probably need to sit as an organization and figure out, how to have a class here for, and maybe you want to gear it towards the fact that you're admitting swing bed patients, which are skilled nursing instead of acute patients. And then what's the most important thing you learned in your tick care? Guess what? Surveyors ask that question and it catches people off guard. They don't really stop to think about it. So I'm giving you a heads up to kind of think basically ahead on that. And then what's the day-to-day that you need to understand with people and pay attention to? Those in nursing homes know, and it still holds true even through the pandemic, the most deaths we have in nursing homes are between Thanksgiving and the first of the year through Christmas. And that's because people are lonely and they die of loneliness. So there are all sorts of things that are underpinning these patients that you've gotten where you are dealing with their current clinical issues. But the mental health piece is a huge piece towards their healing and or impacting their healing. Becky, the next slide.
Kerry, I was also just going to share, the state of Indiana has a primary trauma-informed care learning collaborative that a few of our hospitals are participating in. And the question, what is the most important thing you learned during trauma-informed care training, is I definitely have a deeper respect for the impact that trauma events have on chronic conditions and the impact it has on your overall health in the long run, even if it's a one-time trauma that happened as a child and the impact that it has on your adult life. So some very interesting information that's being shared. And if anybody would like some more resources related to that, I'd be glad to share.
And I'm glad you share that too for multiple reasons. But one is, as people have been productive adults with a major traumatic event from childhood, like you said, it can be singular, it can be ongoing abuse, whatever. What happens as we get older, our brains can't hide it. We don't have the energy to keep it in the background. That's why I think we're seeing more of the dementia with behaviors in nursing homes now. We're living longer. So we're living past our ability to kind of keep those things hidden in the shell of our brains, and they're coming out. And I've said for years and years, I can tell from the women in nursing homes who have lost a baby or perhaps had an abortion because of the way they're holding a baby doll. You can, if you try and separate that baby doll from them, they will go crazy, literally and figuratively. So I think it's important that we get all the training that we can for ourselves. Actually, it helps your own family in the long run, but it's going to be important for your patients, and it's going to be important from our standpoint, what we're talking about today, which is staying compliant with state and federal regulations. All right, so the next slide, I think, Becky, we can, oh, you have it, San Francisco. I put this up as an example because there are plenty of places, and you can search them online, who have very good trauma-informed care programs that have had them for 5, 6, 7 years. But what I have highlighted here in red is what made me pull this one. First of all, they're training like 45,000 staff hours. They've had training in TIC. So they're well-versed in this. But their goal is what impressed me: decrease workplace stress, improve morale, promote employee wellness, which would improve the services they provided to the city's residents. I just think that's a cool statement for your staff and for the care that we want to give our patients. But I have this here as an example. And one of the things they do, for instance, to keep this in front of people is when they go into certain meetings, they'll take the first 3 to 5 minutes of a meeting, say, does anybody have anything they need to share? That's it. And it just kind of keeps it. Sometimes I'm sure they do share things, but it keeps it on the forefront of our brains and our activities that we are dealing with people every day, that unbeknownst to us, they probably have been through a traumatic event or are going through a traumatic event. So the next slide, Becky. All right, so the culture, I've used this as a worksheet for you if you want to just have a discussion with your own teams. What does the community know? What can you provide? Is trauma-informed care being talked about, for instance, in your skilled facilities, in your community care facilities, those who take care of elderly or others? You may have some that help with wheelchair bound patients, so forth. So it's a chance for you to talk about what's going on and how you can coordinate with your community. So what examples would you have? And then, well, what do you do to recognize the employees? Again, I use San Francisco with 9,000 employees, and they do follow up all the time. And they have 9,000 employees. So, the question is, what are we doing on a more routine basis to recognize when somebody's having a rough day? I did an executive training period at Walt Disney. I think it was the first time I was in hospital administration. It was like in the first year. It was required for those in administration. Really, really cool program. Basically, what you did is you went in the morning and learned the Disney way, and then you went in the afternoon and they put a freaking uniform and name tag on you, and you had to go out in the park and put it into practice. And you went back at night, and then you changed what you had learned into your own industry, in my case, healthcare. But one of the things that impressed me about Disney, if somebody was having a bad day, and if you don't know, Walt Disney World has an underground where people come in and leave by tunnels so that you don't see somebody from Frontierland walking through Tomorrowland. And if somebody is having a really bad day or just had a bad experience with a customer, they go to their supervisor and say they're going to take a 15-minute break, and they go down into the tunnels, and there's music there, and there's places to get soft drinks or water, to cool your jets, but you're not doing it in public. And I think that is something we can't always do in healthcare. You can't have a nurse say, hey, I'll be back in 30 minutes if you're in an emergency situation, but it is something to consider how we give people breaks when there are bad.
And Kerry, I think we've lost your sound momentarily again. And we'll just pause and wait for her to pop back in.
And are they letting you know when they are referring patients to you if there are trauma issues? A lot of times these days I see anxiety and depression as diagnoses. I don't see any notes as to what the current issues might be. So that may be something you want to look at also. All right, Becky, the next slide.
Okay. We lost you just for a couple of minutes, Kerry, but I think we're
Gosh.
okay.
Are we all right?
Yeah, you're fine now. You're fine now.
I love the world.
I know.
All right, so here what I've done, I'm not going to go through them, but I've listed kind of questions that come up, and then in red you will see questions that state survey could ask, which means you probably should be asking them. So for instance, we may talk about PTSD these days, but does everybody on your team know what PTSD is? Remember, I'm including housekeeping staff, dietary staff, and so forth. They don't have to know the clinical definition. They have to understand how to come to find nursing staff or others to get help if necessary. So again, these are training topics that you might consider within your own site if you're doing more regular training. All right, Becky, the next one. All right, the next couple of slides are the F tags. If you're not aware, the F tags are the federal tags. When surveyors come in, these are the tags they can assign, and there are several of them. I'm not going to spend time right now reading every one of them. I've listed the key information, but I will tell you for each F tag that is assigned to you, there is a penalty. It's usually financial. It's often a repeat visit from a survey team. Excuse me, and if it's not corrected, then the fines get increased. So it's pretty serious that you understand what the F tags are. We have not had many Swingbed programs cited nationally, but we're beginning to see some now as CMS realizes how much work is going on in swing beds, and yet they're not being getting surveyed like the skill facilities in your town. So this is the one where you have to make sure that you are culturally competent in how you are dealing with, in your case, patients instead of residents. The next slide, Becky. This is the one that is the person-centered comprehensive care plan. That's again a reminder that they're going to look at your care plan and see what you are addressing as far as cultural choices, values, how you're addressing certain diagnoses, PTSD, depression, anxiety, other things. As Becky pointed out earlier correctly, we have a number of health issues that are much worse because a person is so depressed, or now they have cancer. They get depressed, and that doesn't help them work through what all the things and choices they have to do with a cancer diagnosis. So that's a second F tag specifically addressed by those reviewing for trauma-informed care. And the next slide, Becky. And here's the behavioral health training, which you see as a third F tag that can be assigned, which is who has been assigned in your facility to deal with certain issues. And you see under those sub bullets, there's more F tags under that. And the whole point of all of this is not only will you be assigned a fine or corrective action for each of these individual F tags, but what we have found in skilled nursing for the last 5 years is when they assign an F tag, then they also assign a quality deficiency tag. And all of a sudden you're sitting there with 5 and 6 and 7 tags with financial concerns about it. You're going to be losing some revenue there, and they're going to come back until they feel like you've corrected everything. So that's why I'm doing this today in this depth. I want to make sure that you have the proof of what you've done, that everybody's covered, that you're thinking about everything, and it is now ongoing training. All right, Becky, the next one.
And Kerry, for clarification, the financial penalties, is that applied toward your reimbursement rate, or is it a one-time fine?
It's often a monthly fine, and they can be substantial. Some nursing homes are getting hit with $10,000 a month fines right now. So, and did they do the worst thing on earth? No. So it's been a bugaboo that we've been working on, for a long time. About it used to be you got an F tag and you had like a $2,000 fine and, I don't know, 2 months to correct it or whatever. It was simple. It was directed. Now it's all over the place. Like I said, just with this one, with trauma-informed care, there are probably 8 or 9 specific F tags, and then you can get the quality tags on that. So instead of getting tagged with one thing, you're getting tagged with 10. And that's why I say about the financial, they can be pretty serious. So the front end, the better you do to show the state you're paying attention to this on the front end, then you're less likely to get revisited on these sort of things. And that means that you have your training in place, that if they ask questions of all your staff, that they can respond fairly quickly and efficiently in whatever's been asked of them. And particularly, I think that care plan is going to be important, because that care plan, remember, is your patient's involved in that, and the family or patient representative is involved in that, which means that we are passing on all information to them. That's part of the culturally competent, person-centered care rules. That answer the question, Becky?
Yes, yes, it did.
All right, next slide.
And Kerry, I don't know if you can hear us, but you may have she must have unstable internet where she's located. So we'll just wait for a minute.
Can you hear me?
I can now. Yes, yes.
Okay, my phone has just been placed all over the car, but anyway.
Yeah. We do have a question though, Kerry.
Okay, yes.
CAH Swingbed programs only have to follow F tags that are cross-referenced within Appendix W, correct? A question.
That is correct. I would be careful with saying that to a state surveyor, though. I would ask them what they want you to do, because each survey team, Indiana has different survey processes than Illinois, for instance. So I would just check. And that may be something where someone at the state, Becky, can give you some additional information on what they're looking for from Swingbed programs.
Okay. Crystal also made the comment, we do not follow all F tags in Appendix PP unless they are specifically referenced in Appendix W. So is that appropriate practice, I'm asking?
Yes, I think it is for now, but I'm saying this is broadening. Look at the things we've added to your survey process that we didn't talk about 2 years ago. And the reason this is so heightened is because of the pandemic. So they may want to go beyond those boundaries. And if so, then we're going to have some national discussions. So do your best job on making sure everybody can answer those front end questions. And we're less likely to get into which F tag are they going to cite you with.
Okay.
All right, the next slide. All right, those I think again are for self-review. I really did write all these slides for you to use later with your team just as checkpoints. This would be things again your surveyors will be checking for. And remember, these surveyors are trained for skilled nursing facilities. They aren't just for swing beds. In fact, they're getting trained how to walk into a swing bed program and survey them. So I have put in things here that may have more depth than what you are covering. I just want you to be aware of it and then make sure your policies and your training match what you have in writing. Next one. I've put references here, and as Becky told you, I sent a lot of freestanding pieces of information, some of which you already have. But I wanted to make sure you realize survey teams are going to be coming more often to swing bed programs. We have maybe 5 states that I know of now that every swing bed program in the state has been surveyed. So that's going to become more routine. So that means forms, and like the form that, to get your facility assessment for trauma-informed care, anything that Becky can provide that she can let me know we need to find for you, then we need to get it in place so that you can stay compliant on the paperwork. I will tell you, this is not my most favorite topic, not trauma-informed care, but paperwork to talk about, because I think they get so caught up in the paperwork, they forget that we're doing the hands-on care. I think right now they're forgetting we're doing hands-on care with less staff and more complications with our aging populations and having just come out of a pandemic. So you just need to know that survey teams don't do much giving you brownie points for survival. So I want you to be as prepared as possible. All right, so Becky, I think that's the gist of what we wanted to say today. The one other topic that I know they will be asking about, we have been talking about routinely, is infection control and infection prevention. But we've had plenty of training on that. And I'm sure on the acute side, you've had also a lot of training on that. Infection control will be the other huge issue for a state surveyor for a skilled program. All right, Becky?
Okay, I do want to put in a plug that the State Office of Rural Health again this year is supporting critical access hospital staff participating in a swing bed management certificate program. So those individuals that have already taken that certificate program, it is the same course. It's hosted by Hometown Health. And Kerry actually provides the education. It's 6 separate modules. We'll have 1 module per month. But if you're interested in learning more and haven't heard about the swing bed management certificate, contact me. I've put my email address in chat for you to reach out to me, and I will send you all the details. Hometown Health again does support the actual training itself, but Kerry does provide that education, and the State Office of Rural Health through the MBEQIP grant does cover the cost of swing bed staff participating. So if you do participate, very important that you complete that program because they are covering the cost. And Kerry mentioned infection prevention. I also put in a plug. We've sent out several emails that we are having an infection prevention boot camp. It's really geared for infection prevention teams. Several of our hospitals have already registered their infection preventionists for the program. But if you have not received the information and would like more details on that boot camp, please reach out. We still have some spots available. And again, that's November 9th and 10th. It is an in-person meeting in Plainfield, Indiana. So just a couple programs we have up and coming that I think will be very helpful to critical access hospitals as a whole. So any other questions?
So, Becky, right now, I think it would be interesting if people give you feedback about how comfortable they are feeling with what they're doing with the trauma-informed care training at this point, because that may gear us towards some additional information to get out there, programming or
Yeah.
handouts. Okay.
Yeah, so please chat in or just shoot me an email on how comfortable you're feeling. And that definitely, any topic you feel you're struggling with, let us know that, and we'll direct that on our education calls. Again, our Swingbed education calls have moved to every other month instead of every month. And the time has shifted from noon to 11 o'clock to hopefully accommodate more staff. So always watch for your invitations, and but we'll be spending more one-on-one time with individuals over the next year. And a question is, does anyone know of a good speaker for our medical staff and nurse practitioners? And Linda, I'm assuming you mean on trauma-informed care?
Yes, thank you, Becky. Sorry.
That's okay. That's what I thought you meant, but I thought I'd better clarify. We'll work on finding you someone, Linda. And I know of some good speakers, but I also know that they're very costly. So, but I'll work to get someone who can do a presentation for you.
Thank you.
Anybody else? Questions? Okay. Well, have a wonderful day. Enjoy the fall. And I know several are out for fall breaks that the schools have, and just a great time to be out and enjoying nature. So take care of yourselves and just embrace the nice weather as it comes along, and take some time for yourself. Thank you so much. Bye-bye.
Bye.